I'd like to introduce our next speaker, Professor Joe Vieri, one of South Africa's foremost scholars on migration and health. Prof. Vieri is the director at the African Centre for Migration and Society and an associate professor at the University of Witwatersrand. Her internationally recognized research explores how migration intersects with health, urban inequalities, and social justice. Her work places evidence on inclusion, constitutional values at the center of policy and public debate. She's both deeply involved in local and international policy processes, ensuring that the voices and experiences of migrants inform development of humane and effective responses. So we're really honored to have you with us, Prof. And so over to you.
Thanks so much, Fauziam, for such a generous introduction. And thanks to colleagues who've already spoken for the great work that you're involved in and continue to lead, but also for setting, the bleakness of the scene, I think, very well. And what I'm going to try and do in the next few minutes is talk a little bit about not simply around just the right to healthcare for foreign migrants in the country, but much more of a focus on where we're seeing policies, legislation, and government processes themselves contradicting themselves. And the kind of schizophrenia that we see within the political policy world in how the scapegoating of foreign migrants for various failures of the state continues to manifest. And one of the things that I want to flag here is that there is obviously a very established movement in the country, historically looking at the right to healthcare for all, as well as obviously a strong migrant rights movement, also looking at issues around access to healthcare. And we need to find ways to strengthen and forge stronger solidarity between the broader right to health sector and the migrant rights and refugee rights sector, because there is so much that can be done together. And I think that health is one of the issues that genuinely does negatively impact everyone if anyone is left behind in our health responses. So I'm drawing here on work that I've done with different colleagues over the years, but most recently a paper that I published with my colleague Becky Walker that really was looking at the current sort of context around policy and practice in the South African space when we look at health access, asylum seekers, refugees, and undocumented migrants. And I saw that Silo colleagues had used this in their initial invitation, and it's always reassuring when people outside of the dry academic space are finding the work that we write up helpful, because for us what's key is that it reaches different spaces, and this is something that we value, these sorts of opportunities to engage in. And importantly, and it's what we know, right? But what we are seeing more and more clearly and more explicitly is that not only is South Africa as a country and therefore impacting the region and the continent failing to meet its goals and ambitions around universal healthcare coverage, so this is where the national health insurance comes in, it's actively retreating from them. And we're seeing that exclusionary practices, once informal, are now guiding policy processes very explicitly. And we have a long way to go if we're going to be working to ensure that healthcare is truly accessible, is truly acceptable and sustainable for all. And we need urgent policy, legal and institutional reforms to manage this. Without doing so, the most vulnerable, which includes many foreign nationals, will be excluded from essential services. And we know that this is about undermining the Constitution, but also broader global health targets and goals that we're all in support of. So there are four key areas that we really sort of were flagging in this. One is around the legal regression that others have already spoken to, and the focus on the securitization of policy. So looking at securitized approaches to the management of the movement of people across borders. Policy by practice, where we're seeing policy becoming kind of institutionalized simply through things happening rather than through any policy being formally developed or implemented, which is leading to informal exclusion and administrative discretion. So those working at the front lines, whether you're a security guard outside a clinic, whether you're somebody responsible for opening files, whether you're a receptionist or a data clerk, you have actually a lot of power to determine who is being excluded administratively from the system. Legal liminality, so here we're talking about where people are left in limbo, waiting for outcomes on whether it's asylum seekers, whether it's people waiting for renewals, whether it's waiting to hear outcome of refugee status determination or an appeal. People are left in a liminal state. They're left in this limbo. And this has impacts that are beyond simply structural issues around accessing services, but they themselves have a negative health impact on individuals who are waiting, with broad mental health implications. And then finally, and I think very relevant to the conversation today, is that civil society is then rendered the safety net and stepping in and taking responsibility for what should be the responsibility of the state. And we know that this is unsustainable, but not only is it unsustainable, it's also wrong. It shouldn't be that civil society is stepping in to take care of the state's duties. So how do we bring these four challenges together? And they've already been spoken to this morning, and think through what's needed to move forward. One of the realities, and this is something that within our centre we've spoken about for a long time, is that whilst obviously rights-based advocacy is centre, nobody is disputing that, we know that a rights-based approach itself can't win the challenges that we're facing. When we're trying to address political and personal opinions, we know we get stuck into these very, very complicated and difficult exclusionary spaces. So there is a question about whether we need to think about what other arguments we can be using to try and support the state to see its responsibilities. And in this case, one of those would be around a public health argument, really trying to sort of send home the message that if we are limiting access to healthcare for some, it is going to have a negative impact on health of the whole population. And there's various ways that that happens, but particularly if we're thinking about, say, communicable diseases. If we look back at COVID, we saw that there was a moment where we did have a positive and productive public health approach to ensuring the inclusion of foreign nationals, included undocumented migrants, in the vaccination program. We knew that if not everybody can be vaccinated, then the vaccination for the few who are able to access it means nothing. We need a population level intervention. And I think there were really important lessons that were learned there, where the realities of what it means to have good public health and the need that this brings for a de facto inclusionary response was something positive. And can we learn from that? And can we go back to that? How can we think about taking some of the mobilization from that into where we sit today? I'm not going to go into huge detail because I think people are very familiar, but when we talk about the National Health Insurance in its current formulation, it is exclusionary, and it's actually showing contradictions to the Constitution, the National Health Act, and it's a regressive approach to access to healthcare. It explicitly denies access to basic healthcare for asylum seekers and undocumented migrants. And this was reviewed back in 21-22, when there was a whole review looking at the challenges and options that the Portfolio Committee on Health faced when they were reviewing the submissions to the NHI. And what was made very clear, and it's on the slide, but is that the exclusion of asylum seekers and migrants from NHI benefits was unconstitutional and, importantly, counterproductive. So the Bill of Rights applies to all people in our country, and we know that Section 27 of the Constitution allows for everyone to have the right to access healthcare, and clearly does not exclude people on the grounds of their status as asylum seekers. Now, the NHI places South Africa at risk of violating non-refoulement principles if asylum seekers are forced to leave because of failure to access healthcare. Importantly, they acknowledge that the health of the nation was influenced by the health of all within the country. So excluding any inhabitant of the country was counterproductive, and it would fuel the spread of disease and add to the burden of disease. And this is important when we think about, for example, if I have the right to access basic healthcare, but I'm afraid to, or if that right is taken away from me, then I'm not going to be accessing care at the primary healthcare level, where it might be about prevention or it might be about treatment of a condition. Rather, I'm going to be coming to the healthcare system through an emergency healthcare route, direct to a hospital when I'm very sick. So not only is that unfair and affects me as an individual, it also means there's a different burden placed on the healthcare system. So it's counterproductive also in the costs that ultimately are then incurred by the system through preventing people accessing care at early stages. And it was made very clear that it's essential to adopt a clear principle of non-discrimination in the application of the NHI and the inclusion of asylum seekers, undocumented migrants, students, and all children as beneficiaries. So this was made very, very clear in 2022. But these exclusionary practices we know still exist. In 2024, just after Dr. Mozzoletti returned as Minister of Health, moving from the Minister of Home Affairs, when he returned back to health, he was interviewed by Mia Milan at Bekasisa and was challenged about the fact that the NHI Act indicates that asylum seekers and undocumented people wouldn't have the right to access basic healthcare, which by definition includes prevention and treatment for HIV, as well as tuberculosis and other infectious diseases, but importantly around HIV. And he actually said in 24, if there's a mistake in the NHI Act about that, it needs to be corrected. If you refuse people with highly infectious diseases like HIV treatment, it's going to spread around. Then you're working in reverse, because otherwise, without offering treatment, I don't think we'd be able to defeat the disease. So we have this clear recognition from an outgoing Minister of Home Affairs returning to be Minister of Health, which he had been previously, recognizing clearly how nonsensical and schizophrenic these legislative suggestions are in terms of basic public health principles. So it's recognized, yet nothing has been done about it. I won't go through all of the content on these slides, but this is just to bring some voice to what we're seeing currently around challenges in accessing healthcare, but how we're seeing this has now been amplified through the actions of vigilante groups, as has been discussed by previous speakers. But we need to recognise that we will continue to see a number of women delaying antenatal care visits when they're pregnant. Maybe they're also living with HIV, but they're afraid to go to healthcare facilities because of mistreatment. The hospital's strict. I don't know if they're not documented, they can't access. They'll be restricted, but I don't actually know what happens further. And this is another challenge where we know that people working in the health system itself sort of say, well, they can't access, but we still don't really know what happens, but they mustn't access. And this is something that we are seeing where we've got clinics where Dodula and others are outside, that this is sometimes being supported by healthcare workers. And we need to better understand why it is that healthcare workers are willing to support Dodula and others and what that means for better understanding the front line of the healthcare system. It's a public health program. You have people being turned away because they don't have official ID documents. It's ridiculous because lots of South Africans don't have the ID books. Now, this is another space where a broader public health argument becomes incredibly important, because it's not only non-citizens that are being impacted negatively, but also South Africans without ID books. And we've seen this more recently with the actions of Dodula. But where we become so obsessed over this idea of IDs and documents, and we look at some of the suggestions of how the National Health Insurance Act and associated changes in the health information system are being designed, issues around access to documentation becomes even more problematic. I don't expect you to read the slide, but the gist here is really about the fact that at the level of individual facilities, we sometimes see a particular policy or a particular process being put in place at a facility level that is contradictory to what is happening nationally, provincially, or even at the district level, for example. And when we're in situations such as that, what does this mean for how we try and uphold the law? How do we try and uphold things when you've got facility managers directly telling their staff to prevent certain individuals from accessing care, or that they must make certain payments or behave in certain ways? You'll all remember, and it was mentioned, I think, earlier, about the Section 27 judgment confirming that all pregnant and lactating women and children under 6 must be provided with free services at public hospitals. The fact that this had to go to court in itself is, I think, as we've seen with more recent cases, the fact that we're in the situation where these are the sorts of challenges that are having to be introduced at the level of the courts is indicative of just how broken the systems are and how broken as a society we are, to think that a child under 6 should not be able to access certain levels of care because of their status as an undocumented migrant, for example. I want to return to the current Minister of Health. 1st of December was World AIDS Day, and I've been looking back at something he'd said last year, so on the 1st of December last year, and he talked about the importance of a renewed commitment to addressing inequalities and ensuring equitable access to quality healthcare services. And this was with a particular focus on vulnerable and marginalised communities. And he spoke explicitly to migrants, and he spoke explicitly to the need to ensure that there is equality and fairness for everyone, regardless of gender, age, sexuality, ethnicity, religion, or HIV status, and called for this renewed commitment to ensure that we aren't leading to failing public health services, as these communities are already pushed away from vital health and social services. So again, the minister recognizing the importance of an inclusive response, but still not having addressed the inclusive needs that have already been outlined in the promises he'd already made. Oh, sorry. So this is from a wonderful information brochure that Section 27 put together in 2022. The link's down there, and it's a very easy to follow and incredibly helpful resource. And just a reminder that, you know, South Africa doesn't sit on its own when we think about healthcare and healthcare system responses. It has signed and ratified various international agreements, has regional responsibilities, but importantly has responsibilities to all within the country. And we need to recognise that these are the sorts of things that are contained currently in the National Health Policy Framework, that confusions around the NHI are creating even further confusions on the ground. So a reminder that everyone has the right to access free public primary healthcare services, and for higher levels of care. So often when you visit a hospital, for example, there is a uniform patient fee schedule, which then assesses people's income. And from that, there is a decision on the amount of co-payment that somebody must make. And this applies to citizens as well as non-citizens. And we need to ensure that this is not being misinterpreted even further. We have many cases where people are being incorrectly categorized and told that they must be fully fee-paying, for example. But now that we have the NHI bill that is talking about the exclusion of asylum seekers and undocumented migrants, whilst we're still running the patient fee schedule, for example, it's causing even more confusion, and providers have got even greater recourse for claiming that they were confused. And this is something we really must be addressing. So if we look at xenophobic discrimination, this is data from the XenoWatch program at ACMS over the last few years. We see that it was focused mostly around urban areas, particularly in Johannesburg, Durban, and Cape Town. And if we look over that same period at the most common discrimination incidences that were reported, whilst violence remains the most common discrimination incidents, health xenophobia, so being prevented from accessing care or facing challenges when accessing care, is also a key challenge. And this has been emphasised by work that XenoWatch has undertaken, looking at the period of February to November this year, and looking specifically at challenges faced by foreign nationals accessing healthcare. And you can see again that Gauteng is the locus of these challenges. Just a quick reminder that we all work across various domains that are linked to, for example, sustainable development and so on. But what's important is recognizing that in the conversations we're having currently, we're bringing together the global migration governance agenda, so the management of international migration and thinking through the relevant compacts that exist around that, thinking about the sustainable development goals, and then the global health agenda. And actually, all of these issues come together when we're thinking about various issues to do with the efficient, correct, respectful management of refugee and immigration systems. When we think about global health, what's important is to recognize that there is a lot on paper and a kind of very growing, very strong, committed movement globally around ensuring the right to quality healthcare for all, including for migrant and refugee groups. And this is something that South Africa has been part of these discussions, has been part of these dialogues, has been part of signing on to these various declarations. An important point is the World Health Organization and the current Global Action Plan, the GAP, on promoting the health of refugees and migrants. South Africa is part of this process, and in 2024 to 2025, the National Department of Health, in collaboration with WHO, undertook a national health system assessment to explore responsiveness to migration and displacement, and simultaneously undertook a national migration and health research agenda setting exercise. Now, the outcomes of these are due to be reported in the next month or so, and are another important hook for us to all make use of in terms of South Africa's making certain commitments globally and publicly around migration and health. And it's going to be important that we find ways to work with the department to utilize these commitments and utilize the promises that they've made through the system assessment and so forth to upholding certain actions. Something that has been interesting to see, and I think more work needs to go into this, and maybe working with colleagues specifically who are working in the field of the migrant mine workers, is thinking about several processes that have sort of happened in the last year or so, looking around the Mine Health and Safety Amendment Bill, looking at a new, renewed and revitalized approach to looking at tuberculosis, as well as bringing in interventions to look at gender-based violence, safety and security for women in the mining sector. Now, obviously, all of these have implications for migrant mine workers, and I think it would be important for us to be following and looking and understanding what's happening in these sectors to see what that might mean for a broader response nationally. And then, just as I come to an end, in 2024, the department released an important document, which is a zero draft policy advisory, which was a discussion document prepared for the National Planning Commission looking at refugees, migration, health and development. In this document, the National Department is very clear. One of the most important steps in achieving South Africa's UHC, Universal Health Coverage, objectives is addressing health disparities for migrants and refugees. South Africa can create a healthcare system that is resilient, inclusive, and sensitive to the needs of all citizens, including migrants, by implementing policies that address workforce distribution, healthcare access, and resource allocation. Adopting these recommendations will increase South Africa's commitment to social justice and equity in healthcare, assist sustainable development, and be in line with national priorities. So hearing this directly from the Department of Health is something incredibly important. There is a recognition that by leaving certain groups behind, we're doing a disservice to everyone in the country. This is being launched next week, I believe. Collective Voices for Health Access have been doing a lot of work, including in partnership with LHR and CACS and others. And one of the outcomes of the work they've been involved in is production of a new an updated brochure information leaflet around access to healthcare in South Africa, which I think is something that is going to be very valuable for everyone. So I'm sure colleagues on the call are part of this as well, and this will be shared as soon as it is finalised. So I'm just going to finish there and just remind us of some of the words of our current Minister of Health. Thank you very much.
Thank you. Thank you so much, Prof. Yeri, and for that really critical contribution. I think your intervention does remind us that access to healthcare is not only a legal requirement under the Constitution, but it's also a public health imperative, and really taking that nod to COVID-19 and also the HIV and AIDS pandemic and how it has broader implications on public health care, as you've indicated. The exclusions that you've laid out, both formal and informal, are not only unjust, but also really deeply counterproductive and undermining broader health outcomes for everyone in the country. And so the framing of health as a site where discriminatory policy, administrative discretion, and the legal limbo intersect is incredibly important. Additionally, your call to build a stronger solidarity between the migrant rights sector and then also the broader health rights movement is timely and necessary, especially as we're heading into the NHI as well, and the implications of excluding migrants to healthcare as well. And so these are not just parallel struggles, as you've indicated, they're all deeply interconnected. So again, thank you for that continued leadership in ensuring that research informs not just policy, but also justice. So thank you very much.